All right.
Sounds like we're ready to go. Dr. Aurora, you want to introduce our guest and
Yes,
welcome everybody to the
absolutely.
call?
Sounds good, Mark. We are excited to have, it sounds like over 100 participants have signed up tonight. So we're thrilled that you guys are ready for an update. And we're thrilled that Dr. Harris, our own state health officer, is here to give us another update to the Medical Association of the State of Alabama. And we have Dr. Mike Saag, of course. Everybody knows him, and he is gracious enough to share his time with us, as well as David Thrasher, one of our MASA board members, who has also been very vocal as a pulmonologist in the Montgomery area. So we welcome our state health officer to give us the update, and we'll take questions from our members here tonight. Oh yeah, so if you have questions, what we're going to do tonight is actually enter them into the chat box, or we have a Q&A feature. Dr. Harris, you want to?
Okay, sure. Thank you very much.
Thank you for joining us. We're really appreciative of you doing this for us.
Thank you very much, Dr. Aurora. I appreciate the invitation. It's always good to speak to you all. I guess it's been about a month since we spoke last time, so I guess a lot of things have happened in the meantime. We have in the past week or so seen just a little bit of an uptick in our cases. That's a little bit concerning. Our daily numbers have been typically in the 150 to 200 range, but we had a couple of days of around 300 cases. They were not clustered in any one particular part of the state, but from several places. Our percentage of cases that are positive has jumped really for the first time in a few weeks. We'd been around 3 to 3.5% positive on all our COVID testing, on our PCR COVID testing over the past month and a half to 2 months. We're up to almost 5%. I think we're about 4.8, 4.9% for this past week. So that's a little bit concerning that we're seeing that. At the moment, our hospitalizations are remaining fairly stable. That number has been between 200 and 300 now for several weeks. It got up as high as about 280 one day this past week, but typically it's been around 220 to 230. So fortunately, that seems to be leveled at the moment. The hospital association, who's polled their members, has indicated, and you've probably seen this, that well over 95% of the hospitalized patients are unvaccinated. So that matches with what we've seen in other parts of the country, and I don't think anyone would be surprised to see that. The big concern around the world, as well as here, is the emergence of viral variants. The Delta variant in particular, originally identified in India, has been the variant that has garnered the most attention recently. It's become the predominant one in some locations in Europe, including the UK. About a quarter of all the new cases in the US over the past week or so have been, over the past 2 weeks now, have been the Delta variant. We have located that, identified that in all of our public health areas throughout the state. Although we are not doing our genomic sequencing in large enough volume to feel really confident about what numbers we're seeing. I think because this is a variant that's more easily transmissible than the others we've encountered before, there's no question that we're going to have more of it. And I think we certainly have more of it than we've been able to identify to this point. We found around between 25 and 30 cases, and those cases, most of them tend to be around the centers that are actually doing sequencing, which is no surprise. But as I mentioned, they have come from all parts of the state so far. I think the good news and the news to remember is that the vaccines that we have are protective against the Delta variant, as well as the other variants, the other major variants we see, and that's a message that's really important to get out. We continue to vaccinate as much as we are able, but again, things have slowed off considerably. Typically, we're doing a few thousand vaccines at this point in a day, as opposed to, we had days where we were doing, tens of thousands of vaccines in early April. So things have fallen off quite a bit. We have vaccine available in every part of the state, in multiple locations in every state. We have almost 1,400 locations now where vaccines can be obtained. Anyone who's on this call who is interested in being a vaccine provider, if you have not done that yet, it's very easy and straightforward to do, and we'll be happy to make that happen for you as quickly as possible. There are plenty of vaccine available in our state and in our country. We have a really reliable and predictable amount of the mRNA vaccines that available to us every week. J&J's is not currently available, although we actually do have a stockpile in our state, just like most other states do, of J&J. We have begun to see a little bit of expiration of some of our vaccine stock. That was inevitable. It's unfortunate that we couldn't, first of all, use them, or that we couldn't send them to another place in the country or in the world where they could be used. But there's unfortunately not a mechanism for doing that once they're delivered to the end user. So we have lost a few thousand doses of vaccine to shelf life, which is very, very unfortunate. We have been reviewing the data that was discussed at ACIP recently about myocarditis. I think most of you are aware of that and have been following that. If you have an opportunity to review, the MMWR was published today that sort of contained all those discussions and all that data on myocarditis, and I think it's very interesting. There's no question that there is a signal there in the data. There is a slight increase in myocarditis in males predominantly, particularly under age 30, the 12 to 29 year age group. There's somewhere around 40 cases per million that's seen in that group, and it mostly occurs after the second dose of vaccine. Virtually all those cases resolve without any particular treatment. They do not in most cases cause any serious illness. There have been a couple of exceptions, but not very much. The MMWR study today compared myocarditis, the incidence of myocarditis and the complications that have been identified so far to the risk of not being vaccinated and being infected with COVID. And the risk of infection with COVID is greater in every age group, is greater among men and women in every age group than is the risk of vaccination. So I think it's incumbent upon us to be aware of those risks, to understand that myocarditis does seem to have some statistical association, but it has not changed our recommendation that all people age 12 and up need to be vaccinated. So those were just Dr. Aurora, I'm going to pause there. Those were just kind of the highlights that I wanted to hit. I've got a lot of other information I'll be glad to cover with you, but I certainly want to make sure we have time for questions as well. So
that sounds like a plan. So I guess participants, if you can go ahead and type in your questions into the chat.
While we're waiting for questions, hi, it's Mike Saag from UAB. Thanks for having me. Let me just kind of fill in some gaps in knowledge, because we're throwing terms around and I want to make sure everybody's aware. Just in terms of variants, so the original strain of COVID, SARS-CoV-2, had a certain predilection. We all know it well by now. Mostly was transmitted among older folks. They were the ones who got sick and ended up in the hospital, and had a much higher proportion of those folks who ended up dying. And younger people, for the most part, they did get infected. They could transmit it, but they typically didn't get that ill. Since the vaccines have come out, we have, I'm not sure what the number is in the state, nationally, it's about 85–90% of those above the age of 65 have been vaccinated. So the overall death rates in the country have come down. But so if we transition then to variants, the way to keep it straight, because there's multiple nomenclatures, I think the number one thing to remember is that, let's think geographic, even though they tell us not to, but the first variant we really talked about was the one in Great Britain, and that's called Alpha. And then soon after, there was a variant in South Africa, and that's called, they pronounce it Beta, but it's actually Beta, as we would say here. And then there was one in Brazil, and that's called Gamma. And then finally, the one we've just been talking about a lot, Delta, was originally described mostly out of India. Now, these things, the reason we don't want to use the geographic too much is because it's obviously expanded beyond those regions. Real quickly, what they all have in common is that they're more transmissible to varying degrees, one more than the other, but much more transmissible than the original wild type strain. And the other concerning thing is it varies variant to variant in terms of its ability to cause disease. And I think what we're really worried about, especially with Delta and Gamma to some degree, is that it has more impact on younger people in terms of manifestations of illness that could lead to hospitalization and even death. The final point I'll make is that, well, before I go to that, in terms of relative transmissibility, Delta is about 50 to 60% more transmissible than Alpha. And Alpha is about the same more transmissible than the original wild type. So translated, if in the old days with the original SARS strain, if you were in a room with somebody indoors with poor ventilation, they had COVID and you didn't, you might have to have an exposure for 6 to 10 minutes, and then your likelihood's pretty high you'd catch it. With Delta, you can be in a room for about a minute or a little bit less, a little bit more, and you can pick it up. And the reason for that is that the strain is much more adherent to the ACE2 receptor in the lining. And that's why it doesn't take much exposure and boom, it hits. And the final point of that is that the good news is that the vaccines, especially the Pfizer and Moderna, which are the ones we're mostly using, does protect against infection against all the strains, a little bit less against Delta in terms of Israel had a study today, that showed instead of 90%, it's 65% protective against just getting infected in the first place. But the protection against getting sick and being hospitalized and dying is still in the 95% range thereabouts. So the vaccine really makes a difference. So it looks like we have questions now, and we'll turn to that.
Sure, I'll be glad to address some questions. Just looking at the Q&A, and Mike, thanks for that, and please jump in anytime. The first question says, how long after the vaccine does a myocarditis typically present, and how long before it resolves? The MMWR study today said that somewhere more than 95% of them presented within a week, but I think the median time was actually like 2 days or 3 days. It was actually really quick. I did not see any, I don't recall seeing anything about how quickly it resolved, although most of the cases that were identified and reviewed, there were about 400 of them. Again, almost 100% of them had resolved. So I don't know quite how quickly that happened, but within the period that they were reviewing those. The second question I see there says, any new info on booster vaccine doses or projections? I would say, to my knowledge, we just don't know that yet. Certainly that's being studied. We have, good data now that the mRNA vaccines are protective for more than 6 months, and certainly much likely to be much more than that. But at this point, they have actually publicly stated that. If and when booster doses are going to be needed, I think we just don't know that yet.
Scott, it's important to there's probably 2 reasons why we might get a booster. One is you're alluding to that the duration or the durability of the original vaccine starts to wane. And we'd notice that by more cases and more illness in people who became infected. We're not seeing that yet. The second reason is if a new strain emerges where the current vaccines don't work very well, and then we'd be moving to a booster pretty quickly.
Right. Thank you. The next question says, we seem to be seeing more middle-aged obese patients with COVID over the past few weeks. Is that true across the state? I think that's likely true. I don't have data to quote you on that, but certainly obesity is a risk factor we see for worse outcomes without a doubt. So I would think those patients are more likely to come to attention, even though I don't know the numbers on that. One question says, many of my patients are reluctant to get vaccinated since they have had COVID in the past year and feel that they have adequate protection. What's the reinfection rate in Alabama? I think there's a couple of things you could sort of bring out there. We have had now about, the last number I saw was around between 4,500 and 5,000 patients that we know of who are reinfected. That is people who had COVID who were subsequently diagnosed with COVID again more than 90 days later. I think, again, that number is likely higher because we certainly have patients who don't come to attention if their illness isn't significant enough for them to seek attention. But clearly people are getting infected more than once. The real question I think is, do you still need to be vaccinated if you've had disease? You certainly get some antibody protection. You certainly have some residual immunity after infection for some time, but it's not really thoroughly characterized. I don't think we know how long, and we don't know how effective that is. I think I've heard Mike speak, and I may defer to him as someone who's had COVID and also been vaccinated. You've got pretty good insight on that issue.
Yeah, so you're right. I would say to the people who come in and say they've had it, and say, look, you probably do have immunity. I think there's no doubt about that. What we don't know is how durable that immunity is going to last. And we also don't know whether it'll be protective against these new strains. The chances are it'll be decent for the new strains, but we don't know that. Here's what we do know. Someone like me who had COVID back in March of 2020, I got my vaccine on December 20th of 2020. And I'm working with a lab at the University of Pennsylvania where they'd not just measured antibody, but did neutralization titers. And when I got my first vaccine, just within 4 weeks, my antibodies went through the roof. And what we're discovering is that someone who's had COVID and then gets vaccinated, the immunity is pristine. It's the best of anybody compared to those who've never had COVID. So the best way to protect them is to get them vaccinated. Even though they do have some immunity, the durability is going to be longer, and the breadth. When I checked mine, not only was I active against the original SARS, I was active above 10 to 20,000 titer against all the variants, and even developed antibody and neutralization against the original SARS-CoV-1. I don't know how that happened, but it did. That's the one that caused the 2003 outbreak. So I'd encourage them to get vaccinated just for the ultimate long-term protection.
Thanks, Mike. Just another couple of pieces of data. I mentioned, I see the same question 2 or 3 times there. We do know, approaching 5,000 people who've been infected more than once. I will say we do have a little bit of seroprevalence information out there. There are a couple of places we can get that. CDC, as you know, has been doing, surveillance testing for antibodies, and these are for not for spike protein antibodies like you would get with vaccination, but for nucleocapsid antibodies from natural infection. They update that about weekly. The most recent report was today, and they had Alabama as they found antibodies in about 28% to 29% of the people who were tested. The range was 25 to 34, somewhere in that range. But we know that 550,000 Alabamians have been infected that were diagnosed. That probably means that for every couple of cases we know about, there were maybe 3 more that we didn't pick up on. So probably around a third of the state, not quite a third of the state has antibodies indicate they may have been infected at some point. So the other information comes from Red Cross. Red Cross has been doing testing as well for antibodies, although they have actually just discontinued that on a routine basis. They've done that for several months. We only ever had regional data. We never had specific data for the state of Alabama, but again, usually in the 35% range or so was where they had placed our region statewide as having antibodies. So let's see. And the next question I think is what we just covered about who needs to be vaccinated. The next question has to do with current outpatient treatments. I would certainly defer to Dr. Saag or Dr. Thrasher on that question.
Or maybe I'll kick it off and let Dr. Thrasher follow me. We do have outpatient therapies in the form of monoclonal antibodies. With a question asked earlier about people who are obese or have a BMI greater than 35, they are eligible for this, and it really makes a difference. Here's the take-home point. The Lilly product does not work well against Delta, so we're not using that anymore. The Regeneron product still does, so we're almost exclusively using that. There is a GSK product that's a single antibody that seems to have activity. We have less experience with that, so we've been going a lot with the Regeneron antibody, and it seems to be working against all the variants we've encountered so far. The take-home point here is try to get people tested early as possible. These drugs work best if given within 2 to 4 days of onset of symptoms. Dr. Thrasher?
I agree with you, Mike. We are seeing some people get infected. They've had it twice. I've had 8 patients that had documented COVID twice, and pretty much what you're saying. The Eli Lilly, the bamlanivimab antibody is off the market. We're using Regeneron, and hopefully it will remain effective against the Gamma and the Delta variant. I'm still using budesonide very early in the treatment, twice a day. We are treating people who have already been vaccinated. They got it with a monoclonal, and then still using the steroids after about day 8 if they need it. So you're still checking the pulse oximetry, making sure that people's oxygen stay good, just like we have before, Mike.
Thank you very much. The next question says, any chance the governor or Board of Education will mandate the COVID vaccine for school-age eligible children as our state has done for other vaccines? I'd say that probably just purely politically speaking, that's not very likely. I think there's enough controversy about the use of a vaccine that's still authorized but not fully approved by the FDA. In my view, it's a safe and effective vaccine. I think most of us believe that, but it's probably unlikely to be mandated in our state anytime soon. The next question is about breakthrough infections. It says this person has seen 4 breakthrough infections in the past 5 weeks, including 3 this week. 2 have been hospitalized. 2 new cases today were in 90 years old and up. This seems like a lot for a small practice. It doesn't bode well. Well, I think, first of all, if you haven't thought about this, I think we are specifically wanting to do genomic sequencing on these breakthrough cases when we know about them. We'd like to see if there's any particular trends there. We've been trying to do that so far when we get breakthrough cases. Most of our breakthrough cases have been the UK variant, the Alpha variant, because that's the strain that's been circulating predominantly, at least up until here maybe recently. But again, we've had a lot of breakthrough cases. I think, I think I mentioned to you earlier about 1,200 or 1,300 of those. So that seems to be something we're likely to see. Nevertheless, the vaccine is, much more than 90% effective in preventing serious illness and hospitalization and death, even though it's certainly not 100%. The next question says, how serious is the effect of the vaccine on the coagulation system? I think the best answer I can give on that, probably has to do with what we saw earlier with, let's see. I guess that's coagulation. I think we did see some information earlier, if you remember, about venous sinus thrombosis predominantly in women. It was associated with the J&J vaccine. It was found to be a very rare event. It did lead to that pause in J&J. Further, analysis of all that showed that, again, the risk of being unvaccinated and acquiring COVID is much greater than the risk of complications due to that complication from the vaccine.
Yeah, and just to add in there, a lot of times when patients will come into us saying, it's the vaccine versus not getting the vaccine, that really isn't the question. The question is the risk of vaccine versus the risk of getting COVID. One of the main consequences of getting COVID, one of them is coagulopathies and causing clots. Not just the deep venous, the thrombosis in the cavernous sinus is rare and pretty much unique to the J&J and AstraZeneca which we're not using as much of, but actual clots, DVTs, pulmonary emboli are pretty common among people with active COVID. So you're really weighing out the risk of anything with the vaccine. But so far for regular clots, that type of thing that you see with active COVID disease, we don't see that very much.
Thanks, Mike. The next question is, today is the day the governor is relaxing restrictions with the 4th of July gatherings. Do we think we will see an increase in COVID cases? The public health emergency does come to an end today. That's the one that's been put in place by the governor since last March. It's been extended several times, as you know, 13 or 14 times. Obviously, we don't know yet about the 4th of July numbers. I think anytime you have large gatherings of unvaccinated people, particularly indoors, you're going to be at risk for a lot of cases. And that's especially true when you have these more easily transmissible variants around that we are seeing now. Our message to people is that, for people who are vaccinated, life can look a lot like normal, can be pretty much like normal in many cases or most cases. But for people who are unvaccinated, not a lot has changed for those folks. So we would certainly ask people to continue to exercise caution, particularly with gatherings with other unvaccinated people, particularly if they're indoors for long periods. The next question says, any sense of severity of second infections? I would say, yes, we actually have that information. That comes from Dr. Wilson, and I'll try to get that to you. I guess if you're asking about reinfections and not breakthrough infections in vaccinated people, in terms of second infections, the numbers look fairly similar to first infections in terms of hospitalization rates and mortality, which is around 1.8 to 1.9%, somewhere in that range. So not a lot different there. The same risk factors for bad outcome exist in second infections as they do for first infection.
Let me comment on that too, just for a second, Scott. The very first patient I had that had COVID twice, first time they contracted it in Italy before we had it in Alabama. And that patient died. He died of complications of clotting. Now, I've not had any except that one that was readmitted to the hospital, but I had one that was very, very close. So we are seeing patients that have it the second time. Some can get very, very sick. Like you said, just as bad as the first time.
Thank you. The next question is about, what about patients who don't meet criteria for monoclonal antibodies? Again, I'll ask Dr. Saag or Dr. Thrasher to handle that one.
Well, real quickly, I'd like to see everybody be eligible for that, but that's not in my power to grant that. So we have to follow the rules. And to recap, it's people over the age of 65 or people who have any one of a myriad of conditions ranging from diabetes, if they're over the age of 55, high blood pressure, and then if they are obese at any age with a BMI greater than 35. For those people not meeting criteria, as a rule, they tend not to get as sick overall and don't require hospitalization. But what Dr. Thrasher was saying earlier is using inhaled steroids early on helps. We don't have an antiviral that we can give. They're working on that, an oral agent or two that are in development. Remdesivir has to be given IV, and it's really not given until later because it's 5 days of IV therapy and not conducive to outpatient care. But Dr. Thrasher, maybe you can review one more time what you were saying about what you do for a patient who's not meeting criteria for monoclonal antibodies.
Well, it's been tough. And one patient that you and I both treated together, we almost lost. He was 63, and I'll be honest with you, I'm not at UAB. I don't have as many people looking over my shoulder as you do, Mike. But if that patient were to hit today, if he has a little touch of sugar, a touch of high blood, I would try to treat that patient. I know that's outside the box, but I think this is the best thing we've had thus far. And but the big thing is monitor them, hitting them quick with I think the inhaled steroids work. Monitor the O2 saturation, getting them on oxygen at home early as they can if they need it, and just like we've done before, we call them every day and make hold their hand and don't let them panic and run the emergency room unnecessarily.
Very good. The next question asks, why is genomic sequencing not being done on a larger scale? The answer is we really are trying. It's just something that had to be scaled up. Our larger medical centers, UAB in particular, but also some folks in Mobile and Huntsville have been doing that the most. Our state laboratory has the ability to get that done, although we are still going through a lot of hoops to be able to actually do that ourselves and report that ourselves. Many people send us samples which we can have run, and we can call you and give you the results of the genomic sequencing, although we can't actually file that as an official report to send you. But there is money being made available by CDC to all state public health laboratories to develop genomic sequencing capability. So we hope to have that going more widely in the next few weeks. Any thoughts on high-risk folks such as healthcare workers getting another vaccine different than they received initially, like a different product? Again, I'm certainly aware that there's been discussion about that. You know, there's certainly some plausible reasons that might make sense, but I don't think we have data yet to say about that. We've certainly encountered some people who have done that inadvertently or accidentally, who've gotten one product and then got another one. CDC has addressed that and said there's no need to revaccinate anyone if they completed their series with a different product. And in terms of mixing and matching, though, we do not have guidance on that yet, although there have been some places in Europe that have done that. I think the last story I saw was Chancellor Merkel in Germany actually did that. She got 2 different mRNA vaccines, so it must have worked for her. The next question says, what are the true contraindications to the vaccine? The absolute contraindications to the vaccine just have to do with severe allergy to a component of the vaccine. I mean, I think those are the only absolute contraindications. And in some cases, if it's not true anaphylaxis, it's still possible to receive a vaccine in a setting where a person can be safely observed and managed. I'll be glad to. What I was actually trying to find where those are listed. I'm going to put a link into the chat, into the Q&A or into the chat box, and I'll be glad to share that with you, and you can see those things there. The next question says, a recent meta-analysis found vitamin D to be helpful in reducing severity and death from COVID. Why is it not being promoted more? I think we've certainly heard about vitamin D. I've been on vitamin D since last March myself. I don't know if Dr. Saag or Dr. Thrasher has anything to say on that.
Well, Scott, this is David. I also use it. I also been taking it early on. I'm really not convinced that it helps. I am convinced it doesn't hurt. So everybody that diagnosed with COVID, I'm putting it on it and encourage them to take it until they're vaccinated.
Yeah, I mean, it's really interesting. In a lot of disease states, vitamin D plummets, and that's pretty common. And there have been lots of studies in other disease states where aggressive replacement doesn't change outcomes too much. I agree that I don't think it does any harm. I wouldn't object if people want to use it. I'm not as convinced of the data for it. And the thing to remember is that when meta-analyses are done, they have to be done pooling together robust studies in terms of large numbers and well-conducted randomized trials with hundreds of people. Just think about the vaccine studies with 40,000 people randomized. There aren't many studies like that for a lot of the different therapies that are being touted here and there. So I don't think there's much harm to it. It's not something that I'm recommending personally.
Thanks. The next question says, I've read about high overall efficacy of mRNA vaccines, but do we have data about efficacy of the vaccines for different age groups? I'd say, yeah, I think that is available. And I think it can certainly be teased out from the original studies that were done, but I'm not aware of what it is.
It's pretty consistent across the board. The numbers that you see in terms of the for the original wild type strain, about 85 to 90% protective against acquiring infection, and then the 95 to 98% reduction in hospitalization and death compared to placebo. So it seems to be pretty robust across all age groups. Now, the difference, though, is in terms of effect size. And one of the controversies is, what about the people between age 12 and 18, where you now have early use authorization, at least for Pfizer? And the issue there is that, fortunately, those folks, at least with the original strain, don't tend to have many hospitalizations and certainly not many deaths. So demonstrating that benefit to the same degree, lack of a better word, robustness, as for somebody over the age of 65 is obviously more difficult to demonstrate, but there is benefit. And I think also in that MMWR, Scott, that you referred to earlier today, there's really great data on natural history among children and young adults, as you mentioned. And there's a fair number of hospitalizations. I think there were just 6 deaths that were reported in the comparator group. So not many of those.
Thank you. The next question is about ivermectin. What are your thoughts on that? I'll ask Dr. Saag to weigh in on ivermectin.
Yeah, so ivermectin, as everybody knows, is a antiparasitic. It's fairly safe drug. We use it for onchocerciasis in Africa. We've used it for scabies and that type of thing. In vitro, there's a hint of antiviral activity, and so that's been encouraging people to think about it, try it, use it in clinical trials. And I've seen meta-analysis on this, and again, it falls back into what I just said, that there aren't enough robust large studies showing efficacy. So it's hard for me to get enthusiastic about using it. And unlike vitamin D, there are side effects that you probably want to avoid here. What I found interesting is that the company that makes it, which is Merck, came out and unconditionally and definitively said, don't use it. I've heard people who are critics of that comment say, well, yeah, they don't want you using it because they're developing one of the oral antivirals. That's true. They are developing an oral antiviral. But I would think if the drug actually worked and they had data that it worked, they would not hesitate just in the public health space to promote it for that. And they're not doing that.
Thank you. The next question says, I've had young females question influence on fertility with vaccine use. How should they be counseled? This is certainly something that we've been hearing for some time. I will tell you that while this is certainly not my area of expertise, we've had a number of conversations with fertility specialists who say there's really no plausible mechanism by which this could cause infertility. Ultimately, that we'll find out when the vaccines have been out long enough. But there are many women who were pregnant who were, turned out to be included in those vaccination trials, and women who have been vaccinated who have become pregnant. I think ultimately we need more data, but there's no reason to think that's an issue.
Yeah, and for men, there's a couple of small studies. Again, I'll be just as critical of those because of the numbers. But they've looked at sperm counts in men, and there's no difference. If anything, it ticked up a little bit, but I wouldn't call that significant. But for sure, it didn't drop. So I agree with you. I don't see a conceivable mechanism. We've all been surprised by things in our lifetime practicing medicine. I'm not sure where the whole idea came from. I never heard it discussed in the scientific circles. I've seen it on the internet. And I don't know if that's part of a campaign of disinformation or misinformation, but there are no data to suggest this at this point in time at all, nor a mechanism to support it.
Right. Thanks. The next question says, have we been seeing a big increase in cases and hospitalizations in recent weeks after people are relaxing facial coverings? I would say we have seen an uptick that I mentioned earlier. Overall, most of the country has had a fairly flat case numbers for some time, although at this point, just under half the countries have seen I've seen an increase in the past 2 weeks. So I think, we get these questions sometimes, and I think sometimes they're meant to say, why didn't our cases go way up when people stopped wearing face coverings? I think that's what's kind of implied by that question. I would just say, I don't think that's the only issue that ought to be considered. Face coverings aren't the only reason that our case numbers go up or go down, but they have very good evidence to support that they can prevent
I think the way that I think about this is that it's a little bit like a wildfire. You can have tinder that in this case might be a cluster of folks who are unvaccinated. And if the virus doesn't penetrate into that cluster, nothing would happen. But once it does, then especially if they're indoors and close contact, it can spread like wildfire. The case of the camp in Texas that just got reported of lots of campers getting infected, it was bad timing in terms of a virus entering, but we haven't seen that yet in Alabama. But I think a lot of us are concerned about the relative low vaccine rates and the Delta variant entering, and we're seeing sort of explosions of the epidemic in Missouri and some other states that are in a similar situation as us. So I think, to me, the data on deaths is pretty sobering. And just to share that real quick, in the month of May in the United States, there were 18,000 deaths from COVID. 150 of the deaths were among vaccinated people, and the remaining 17,850 were unvaccinated people, over 99.2%. And to June, there were 10,000 deaths in the United States. Same story, 99.2% of those who died were unvaccinated. And if that's not a rallying call to say, let's get vaccinated, to me, those are all preventable deaths. And there aren't many things in medicine that we can prevent that dramatically, and especially in the short term, than using the vaccine. And I can't say that strongly enough.
I agree with you 100%, Mike. Now, we are seeing a lot less patients having to be admitted to the hospital, but what we are seeing is these are people in the 40s and 50s. Granted, most of the people over 60, a great majority of them at least have been vaccinated. All the ones that we're seeing in the hospital now are unvaccinated patients, and a lot of them are in the 40s.
Thank you. It looks like we were answering questions from the Q&A, but we've got some in the chat box as well. So let me try to pick those up. The first one has to do, if you've had COVID, should you be vaccinated? I think we've covered that, but if you have more questions, please speak up. The next question says, is Delta variant associated with a lower lethality? I would say I don't think we know that at all. I don't know that there's clear evidence that it's more lethal, but I don't think we have anything to suggest that it's less lethal.
There's a study out of Scotland among young people that showed it was associated with higher death rates. And so I think we're concerned about that. For sure, the Gamma variant, the one that originated in Brazil, I think is pretty well demonstrated to be more lethal. And there is an outbreak right now in the state of Washington of Gamma virus, Gamma mutation. We're hearing a lot about Delta, but the Gamma is hitting out there, and health officials in Washington state are quite concerned.
Wow. The next question is asking, I believe it's asking if the vaccine is going to be mandated for people who work at UAB. I have no idea on that one.
Wow. I wouldn't be surprised, at least for the healthcare workers, for sure. Right now, we have medical students, et cetera. I think a lot of it may hinge across the board on the approval of by the FDA for full approval for some situations. But my sense is, and I'm not speaking on behalf of UAB, I think fairly soon we might hear there might be a decision about that. I wouldn't be surprised if that was mandated.
The next question says, what are the positives and negatives to implementing incentives to vaccinate our population? I think we really we've spent a lot of time struggling with that. Here in Alabama, we have some limitations about what we can do as a state agency to incentivize people. The vaccine lotteries that you've seen in Ohio and a couple of other places are actually statutorily not allowed in Alabama. We cannot have a lottery or any element of chance involved. It's possible that we could just pay everyone who wanted to get vaccinated. We could provide an incentive to every person, but we've to this point vaccinated 1.8 million people already, and it's going to be challenging to think of a way to fairly do that. Additionally, we need the help and support of the legislature to appropriate American Rescue Plan funds anyway. We don't have access to CARES funding anymore. All those funds are obligated, so it would have to come from American Rescue Plan funding, and that's that the legislature's got to be involved in that. I will tell you, we have actually talked to many different businesses and schools and private organizations and others and tried to get them to incentivize people to the extent that they can. We hope that employers will continue making will make vaccination easy for their employees. Maybe they can provide paid time off for people. Maybe they can give them some other type of incentive to get vaccinated. In our around the state, our county health department people are reaching out to their top employers in every county to have those conversations with them about the things that employers can do or that schools can do. But we do have some limitations about what the state actually can do. I will tell you the vaccine lottery in Ohio generated a lot of buzz. I thought it sounded like a good idea. It did not markedly increase their vaccination rates beyond the first 2 weeks. They had about a 9% bump over the first 2 weeks, which is not nothing. But then that sort of settled down to where they had been before. The next question is about convalescent plasma. Some people who had COVID were not getting vaccinated because they were donating convalescent plasma and were told they couldn't after being vaccinated. Why wouldn't this be allowed? I'd have to say, I don't know the answer to that. Have you guys heard of that?
Yeah, we're not collecting much convalescent plasma, at least at UAB anymore, with the availability of the Regeneron antibody and previously the Lilly. We're not doing that. I'd say go ahead and get vaccinated. That would be a smart thing to do right now.
Yeah. The next question says, is there any justification to test vaccinated individuals who are afebrile or have no symptoms? I would say, generally speaking, we don't test people who are asymptomatic. There's not much reason to do that. In fact, whether they're vaccinated or not vaccinated, we generally speaking aren't going to do that. For people who have symptoms, of course, then you would treat them like you would any other patient, regardless of their vaccination status. You could still test them as well.
One quick comment, Delta appears to present a little bit differently, often like a common cold. So runny nose, sore throat, and somebody feeling kind of bad, test them for COVID, especially if they're older, especially if they're at high risk. But that's a really important pearl in terms of, it's not fever so much, it could be, but it's mostly just a common cold, often without fever. Again, the idea of getting tested early, getting the diagnosis quickly can save lives in terms of getting monoclonal antibody to those who are eligible.
Good. Let's see. The next one is, this may be for Dr. Thrasher. It says, it was mentioned budesonide being used early on. Should budesonide be used in isolation, or is Symbicort acceptable?
Well, I have used budesonide because I think it's easier to get it in there with a nebulizer. Short of that, you could use it in inhaled steroids without a nebulizer. I do tell people, if they can, do it in the garage or on the porch, away from their loved ones in the house. And I also try to do, if they can't do that in the winter, I say go into your room and do it there so you don't spread the virus all over the house.
Yeah, thank you. The next question says, how do rates of hospitalization and death compare to those rates in states with much higher vaccine rates? I'm not exactly sure what the answer to that is. Deaths are down everywhere. Fortunately, we're very happy to report that. I think it's been fairly consistent that a fairly standard percentage of folks who are infected end up hospitalized, and then subsequently a certain percentage of those folks aren't going to die. So it's probably overall numbers of cases that are going to directly relate to your rates of death or your rates of hospitalization. I will tell you that those particular stats are easily available on CDC's website. They have all of those numbers available, and you can compare them. Can a nonprofit entity cover the admin fee for school students to get mass vaccinated? I guess I'm not quite sure what's being asked there. People who have insurance, as you know, you can certainly bill their insurance and for an admin fee. For people who are uninsured, then HRSA has a program that you can do that, which you have to enroll into. Either way, you have to be able to either bill their insurance provider or bill HRSA. So there's certainly some nonprofits who are doing that, but it's people who have enrolled in those programs and know how to do that. I hope that's answering your question there.
All right. Well, it looks like we got a lot of questions answered, and it's almost to the end of the hour. So Dr. Harris, Dr. Saag, Dr. Thrasher, just any last comments before we close up?
I'll just say, again, thanks very much for having me. It's always great to be with you. Please reach out to us anytime if there's anything we can do to help.
That sounds wonderful.
I don't have much to say except that we are in unprecedented times. This is now 18 months. We don't know exactly what the future is going to hold. But I think when you pull back to the big picture, the fact that we have at least a couple, if not three major vaccines that not just work, but work very well, is our exit strategy from this pretty horrific epidemic. And we as clinicians, we as physicians, providers, have a lot of clout when we talk to our patients, and encouraging them to get vaccinated makes a difference. So I think all of us should be helping encourage patients, explore with them what their hesitation is, and as best you can answer their questions and see if you can work through any barriers that they might have to be vaccinated.
I agree with Mike. Our biggest treatment weapon we have right now is the vaccination. We debate what treatments are best, but if everybody got vaccinated, this thing would be over in 30 days. I know that's not going to happen, but people do listen to their internists, their family practitioners, and doctors in Alabama are really the weapon we have to convince the 50% of the people who aren't sure about this vaccination. So I would encourage all of you to talk to your patients. It's very difficult. It's very difficult for us to not to get angry. We've been in the trenches for a year and a half. It's tough. We all get that, but we just have to sit down and rationally talk to some of these people who have genuine concerns and genuine questions.
There was one last question that just got entered that may be somewhat important. Any idea when we may see the mRNA vaccines receive full FDA approval, as that is a barrier for some who are vaccine hesitant?
Yeah, good question. I think the short answer is no, I don't know. I've been on calls with CDC, which is not the same as being on calls with FDA, but on calls with CDC, who said it's possible something could happen before the end of 2021. But I don't think we really know that.
All right. Well, thank you everybody for your time. I think that the Medical Association has been very grateful for the partnership here, because when you're in the middle of a pandemic and you don't have a lot of time for evidence-based medicine, the best way that we can fight this virus in our own communities is through this collaborative type of communication as we have evidence-based medicine and our experts can share it with us. So thank you again. We really appreciate it. We hope to do this again. Good night, everybody.